Menopause is a well-known benchmark in a woman's life that signifies the end of her reproductive years. And though men don't necessarily have a similar point for their own fertility, they do experience an age-related process called andropause, sometimes referred to as male menopause. Lisa Fasone says that when men hit the age of 40, they start to experience a natural decline in testosterone.
The difference between male andropause and female menopause is women have a very abrupt decline in their estrogen levels with very abrupt onset of symptoms versus men, because this decline is very gradual, it decreases by about 1% per year after the age of 40.
Fasone is a physician assistant with Northwestern Medicine who specializes in urology. On top of the natural decrease in testosterone, there are various lifestyle factors that can further impact hormone levels.
Men who have chronic diseases like kidney disease or diabetes, men who are overweight or physically inactive are at higher risk for having lower testosterone levels compared to their counterparts who don't have those diagnoses. So that also plays a role in how quickly the testosterone declines.
Having so many contributing factors means that it can be hard to diagnose a case of low testosterone. Fasone says most of the symptoms are vague, so some patients won't realize they're actually all connected.
Some symptoms of age-related low testosterone is fatigue, low libido or low sex drive, erectile dysfunction, mood disturbance, sleep disturbance, difficulty gaining muscle, difficulty losing fat. So those are pretty vague. There's a lot of explanations why an older man could have those symptoms. Some can be normal age-related. Sometimes if a patient is obese and they have sleep apnea and they're a type 2 diabetic, those things could all cause all of those symptoms, right? So a lot of those symptoms are not specific to low testosterone. They can be multifactorial, meaning there could be a lot of different things at play causing those symptoms.
And since it's a slow process, many men don't notice anything's wrong until years down the line.
For a lot of patients that we see, they've probably had this diagnosis and these symptoms for well over a decade, but they just the change wasn't so abrupt that they didn't really think anything was wrong. Sometimes we'll ask patients, they'll say, I've had these symptoms for 10 years. And we'll say, okay, well, why'd you make your appointment today? What changed 2 weeks ago when you were scheduling this appointment compared to 5 years ago? And you'll have varying responses, but some patients will say, my wife got tired of me, complaining, and she finally made me schedule. Or, some patients will say, well, I had a medical problem and it really kind of made me look at my health in a different light, and I really want to take my health seriously. And so it's kind of moments like that in a patient's life where they finally realize that the things that they used to do or the things they want to do, they can no longer do. And then a lot of times that will prompt them to go see a healthcare provider.
Instead of dealing with vague symptoms for years, is it possible for men to be proactive about their hormone health? If the decline often begins at age 40, should that start routine screenings for testosterone levels? Unfortunately, Fasone says that wouldn't be effective because most men don't have any symptoms early on.
The technical diagnosis of hypogonadism or andropause is men have to kind of meet at least two criteria. They have to have low testosterone levels, meaning total and or free testosterone checked on at least 2 occasions, and have symptoms. So if a man does not have symptoms of low testosterone, the recommendation is not to test for low testosterone because they wouldn't qualify for that diagnosis regardless, right? If a man comes in, he's feeling great, he has no concerns, there's no reason to check for testosterone because he wouldn't probably benefit from having it replaced, even if it was low, because he's not symptomatic.
Testosterone replacement therapy is often the go-to treatment. And though emerging research is looking for more personalized and holistic methods, patients today typically receive TRT through one of several delivery options.
Main options are intramuscular injections, which is a solution that you inject into the muscle. Another option is oral medication. Generally, that's a medication a patient would take by mouth. It's a pill you take twice a day. There are topical applications. So topical patch, topical gel, or topical cream that you rub onto your skin daily. And there's also an option where a patient can come in, have a procedure done every few months where we insert pellets that are really slow acting. Those slowly release testosterone. The pellets get inserted into the glute muscle or the muscle in the butt cheek.
Fasone says choosing the route of administration is very dependent on the patient's experience with testosterone replacement and personal preference. Those who are scared of needles may choose to take daily pills, while patients who can be forgetful may not be the best candidate for oral medication.
Some patients, if they're around young children, I prefer they not use topical application because there's a risk of transferring that to a small child. If you don't wash your hands correctly or you don't put a shirt on right away, that medication can transfer to kids. And so you have to ask who's in the house with you, who has access to your medicine cabinet, stuff like that.
Research has shown that exposing kids to topical testosterone can cause premature puberty and enlarged genitalia. So having kids in the house can impact which delivery method a patient chooses. Fasone also notes that for first-time patients, she doesn't typically like to start with a pellet implant.
It's slow acting, but there's no way to take it out. And so if a patient didn't tolerate it well or didn't have good results from that, there's nothing we can do to reverse it. So I prefer to get a patient on some other type of replacement therapy first to make sure they tolerate it okay before we go to the implant.
The method of administration also plays a part in the side effects men can experience. TRT can affect various systems in the body, including acne, hair loss, and fluid retention.
Some of the main side effects and things we watch for is we watch for blood counts to make sure the hemoglobin levels don't get too high. That can increase a patient's risks for blood clots. There's also some studies to show that patients are at increased risk for heart attack and stroke with taking testosterone. There's been studies done that say that testosterone can increase your risk for prostate cancer. That's been somewhat debunked. There's kind of new studies that say not really, but what can happen is if a man were to get prostate cancer or be diagnosed with prostate cancer, the testosterone it kind of feeds the cancer and can make it more aggressive. And so that's something that we have to be mindful of.
Because of these side effects, some men aren't good candidates for testosterone replacement therapy. Fasone says physicians need to be cautious when prescribing TRT to patients who've had a recent heart attack, stroke, or have a history of breast cancer or prostate cancer.
Patients who have untreated sleep apnea should not take testosterone because they're increased risk for stroke. Patients who have uncontrolled heart failure as well, you have to be mindful of prescribing. But that sounds like a lot of kind of contraindications, but in the big scheme of things, that's very few. So most patients outside of that really would qualify and wouldn't have any contraindications to using it.
Which is great news because the benefits of this treatment can be life-changing. It can improve energy and mood, boost libido, and aid in maintaining bone density and muscle mass. Crucial components for healthy aging. You can find more information about Lisa Fasone and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farrah. Our production manager is Jason Dickey. I'm Greg Johnson.